I have to apologize with every my being. I was house sitting for a friend last night, and in the middle of the night, like 3 times in a row, like the fire alarm went off, and there was a fire, and we had to, like, I had to take the dog out of the house. I went to my house, and I thought I set the alarm, and I didn't. So here I am.
Thank you, Michelle. We're just going through the icebreaker, so thank you.
Yeah.
We did some introductions, and Abby did a great job of kind of going through the review. So she already went through the second slide.
Okay, this one?
Yeah. So she already went through that, and we were there. Awesome. We were just waiting for your pictures. We thought
Here
there'd
we
be
are.
pets.
That's me, and that's Abby.
Awesome.
She's wonderful, and I'll introduce her because I think she's a lifesaver, and she's been saving my life these days, so, especially this morning. So Abby is a student at Wilfrid Laurier University and a pending registration social service worker. Abby works within the violence against women sector as a trauma counselor and shelter support worker, and facilitates self-advocacy empowerment groups for people seeking employment who are receiving social service supports. Abby has experience in group facilitation and family-based trauma work. She's doing her MSW practicum placement at CAMH's Forensic Dual Diagnosis Specialty Service, and she's keen on continuing her career serving people with developmental and intellectual disabilities and dual diagnoses. I'm very pleased to have her co-facilitating today, and I think it's quite important that we lead this new generation of students toward work within this sector, because I think it's quite important. So before we start, I think it's important because while we are talking about this topic in relation to people we support, I think this is a personal topic that sometimes people may relate to or have family members that are struggling with it, or friends or themselves. So some of you might be struggling with substance use or substance use disorders and find that this information triggers you or heightens your emotions. And that's completely and totally normal. So if you or a loved one is struggling with substance use or substance use disorders, there is help available. Should you require assistance navigating the resources available in your community for substance use and substance use disorders, please don't hesitate to reach out. We're happy to provide some information or some contact information of appropriate referrals that perhaps you or your loved ones can seek. And when you are ready to do so, I encourage you to speak. If it's through work, your human resources officer, or you can contact me, and I can kind of guide you to an appropriate referral or whomever. But find out how you can get accommodated at work while you seek treatment. Make a plan with your loved ones, see if that's possible. And if you're finding this training is stressful or finding it difficult to sit through, take a break, and please find support while you're doing so. But if I ask if you do that, check in with us first so we don't see the numbers dropping off and wonder where you went. So Abby, the icebreaker activity. We'll start with this, sort of a general overview then. Substance use in individuals with intellectual and developmental disabilities. So, just this thing here. Sorry, 1 second. So substance use or substance use disorders are common among individuals with intellectual and developmental disabilities. For the purpose of this training, I'm going to say people with IDD, and that's going to be what that means. Several studies suggest increased prevalence rates of substance use disorders amongst individuals with IDD versus the general population. Individuals with IDD often experience more and more severe negative consequences from substance use and substance use disorders as compared to patients without IDD. And I'm not talking just about like the physiological consequences. I'm talking about sort of like the prognosis across a longer period of time, like what happens to them societally, what are the risk factors in terms of justice involvement, that sort of thing. So we have a question, and you can put it in the chat or you can feel free to chime in. But the question is, why do we think that is? Like, what factors contribute to this exaggerated expression of the negative consequences from substance use? Anyone? Why do you think that is?
I have a thought.
Why?
So before you joined, Jennifer was talking about how a lot of either staff or I'm thinking also, you know, family members and supports of people with IDD can be very overprotective. And my guess would be that a lot of the time, if people with IDD, if it's discovered they are using substances and have a problem with substances, that overprotectiveness might swoop in, and the consequences will be more severe for them than for the average person. Like they might get cut off from all their supports from whatever they were doing. Yeah, and then I also think that a lot of people with IDD have more health concerns than the general population as well, and a lot of substances can exacerbate that.
Absolutely. I think those are both quite on point. No, PowerPoint on PowerPoint. No, but you're absolutely right. And I think also this like overprotectiveness or like an infantilization. I always pronounce that word, but it also kind of is like an issue in terms of teaching about substance use and drugs and alcohol and all that stuff, you know, as someone's coming up and like being raised by their families, right? Because they don't necessarily focus on, you know, teaching kids about drugs and alcohol because they assume that it might not be an issue for their child with an IDD. So we have some in the chat. So we have higher rates of poverty and in some cases isolation, 100%. Coping mechanisms, yeah. So these are all absolutely true. You know, the societal factors that affect most, you know, the general population and make prognoses worse affect people with IDD a whole ton more. Any other comments before we go? Because we have the answer. And this is why. The risk for developing substance use disorder or experiencing more negative consequences from substance use is increased due to causal factors that make people with IDD more vulnerable in general. So adverse life effects, and we know this, right? Like if you think about the people, I don't know how many of you have experience working with people who have had substance use disorders or issues with substance use, but you know, many of them come from a very traumatic background, and our guys with IDD have a higher rate of that. Inadequate coping strategies, someone mentioned that in the chat. Absolutely. We know that a lot of people tend to use substances to cope with things that they're going through. Self-medicating is a term that we hear all the time. That's 100% right. Low socioeconomic status, we know that that's correlated with substance use. Loneliness, the desire to fit in, increased susceptibility to peer pressure and lack of social skills. Unfortunately, that's something that, you know, in my role at FDDSS, we see a lot of the time that people are coming in through the forensic mental health system, having committed crimes for which they're not criminally responsible, but nonetheless, they committed it because, you know, they got involved with people who were preying on them because they're vulnerable. They gave them some drugs and alcohol they didn't and the people that we're supporting maybe didn't necessarily know the consequences of using those drugs. And then, you know, they want to fit in, they want to feel loved, they want to feel cool. It's the same sort of idea. You know, I know that Deanna and Wendy, when they're teaching around human trafficking, people become vulnerable to being, you know, taken in through that system for those same reasons. They want to fit in, they want to be told that they're loved, they want to be told that they're cool. Well, that's what happens. Cognitive factors that result in an inability to understand the consequences of SU. 100%. I think we, you know, similarly to sexual education, there's not a lot within, you know, the special education system, at least in this province, that goes through what can happen when you're using drugs and alcohol, because the assumption is that you know, we assume that they're not going to use it, which is not true. There's a high prevalence of co-occurring psychiatric disorders. That is true. So, and anything else, Abby, from your end that you can think of that we didn't maybe add to this list? Because we were talking about it yesterday night.
Yeah.
Yeah.
I think we have some more a little later on as well. Yeah.
Okay, so then we'll move on.
In the chat, Michelle, in chat, it was just added a lack of awareness and training amongst those supporting people with an IDD.
Yeah.
Especially around harm reduction. So maybe not noticing signs and and being able to support someone at the beginning stages.
Oh, absolutely. And I think by no fault of our own too, right? Like if you're not involved in that world, like, and I think of myself sort of, when I was in the developmental services sector primarily, right? And I didn't have any experience working with people with substance use or substance use disorders. I didn't know what to look out for. And you don't, we all know like how to tell if someone's drunk or how to tell someone smoked a joint, but like what are the signs if someone's using meth? What are the signs if someone's using an opiate? Like those are things that we don't necessarily know by no fault of our own. But by attending trainings like this or by engaging in some sort of learning on your own, it does become super helpful in being able to point those early signs out and maybe address the problem before it becomes like a huge crisis issue. So, but yeah, thank you for that one. Since caregivers and clinicians are gatekeepers to specialized care and play a crucial role in screening and detection of substance use disorders, their perceptions on substance use disorders are important for providing adequate care for individuals with IDD and SUD. So it is indeed a multi-layered issue. So not only do we not really necessarily have the information to point out that people or to recognize that people have substance use disorders, but also our own biases when it comes to this particular topic have very profound impact on how we support people who are struggling with this issue, which is indeed an issue. It's very similar, when I teach applied suicide intervention skills training, we talk about this a lot. What is your feeling about suicide, and how does your feeling about suicide impact the way that you can help a person who's feeling suicidal? In the same way, what are your feelings around the morality of substance use? And how does that impact your ability to care for a person with IDD who might be struggling with that issue? So it's something I want you guys to start thinking about as we go through the next several slides. Actually, it's something that we'll discuss. So the first question is, what barriers do you feel exist for caregivers supporting people with IDD and substance use disorders and behaviors? I don't anticipate there's a lot, because I know there isn't. I mean, rather, no, I know there are a lot of barriers, but I know there's not a lot of support. Yeah. I mean, we talked about it, like maybe not having necessarily the right information or education or information ahead of time. What else? As caregivers, and I mean both paid caregivers and unpaid caregivers as well, right? Like I'll lump everyone into that.
There was one that was just added appropriate housing resources. And I would even add to that just lack of modified type of programs out there. They just don't fit the needs of the individuals you support.
Yeah, and I think even more than that is like there's also this hesitation, and I'm guilty of it too, to put someone with a substance use disorder sort of maybe in a shared living accommodation with people who don't have substance use disorders. And what is the impact of the drug use, which is it's a thing to consider, but how does that impact the other people that they're living with? And when we're planning for housing and all that sort of stuff, what do? But it's a complicated situation. All right, we have another one in the chat. Appropriate housing. Anything else? What other barriers?
Ashley just raised her hand. Ashley, go ahead.
Something that our team, so I'm on the TAY team at CODA.
Okay.
And so like many of our clients have substance use concerns right now. And so, yeah, we're sort of in that position, like you said, Michelle, where we're sort of learning because that wasn't necessarily our scope to begin with. But something that I'm for sure seeing on my caseload is the hospitals and other support centers for our clients who have addiction concerns are kind of avoiding wanting to help these clients because they sort of refer to them as like group home kids. So because our clients have staff and they have somewhere to go, they might go somewhere to get help and then the hospital sends them home immediately because you have staff, the staff can take care of you. So that's something that we're like really struggling with.
Those so systemic barriers, like big old
Yeah.
barriers. And that is, I think as it relates to substance use, it's a huge issue. But in general, I think when we talk about how the mental health sector supports people with IDD, a lot of the time it's with that. I think sometimes we're guilty of having that lens, right? Like, oh, they have a place to go, so it's going to be
Yeah,
fine. Right? But is it? Because we're going to send them home and they're still going to have the same problem.
exactly.
Yeah, that's a brilliant point. Thank you so much, Ashley.
Thank you.
Um,
Jennifer had her hand up too.
oh,
Sorry.
go ahead, Jennifer.
Yeah.
Hey, Michelle.
Hi.
Hey, I was just echoing what they said, and maybe someone said this and I missed it, but I think there is an assumption in DS that mental health and other sectors should support them.
Yeah.
And I can tell you even more than just an assumed bias from DS agencies. We've had DS agencies that won't offer services to people when there's substance use. So it actually, it's more than just an assumed bias. There's evidence of it in our system. I think the other thing is just allowing dignity of risk. And again, I don't know if you said this, I'm sorry, but the ability to teach and kind of give people with IDD the capacity to safely use and in a true harm reduction, again, because we, have this protective nature. So I think that's also a piece of it, and finding programs that are adapted for people.
All of those are so good. Yeah, I mean, not good, they're bad, but you're 100% right. No, but there are serious systemic issues. And I think that's something we have to recognize. And I don't think it's like a, mental health or DS, like everyone has some stuff that they need to change in order to appropriately meet the needs of these very complex people who we're finding more and more within our system. Like, it's not surprising to me, that Ashley came up and said, most of the people that she's working with right now in the TAY program have some substance use stuff. We're seeing it and we don't know how to adequately deal with it. And there are real systemic barriers and physical barriers, as access to housing is very much that. And we have to mitigate that. So then I ask a very loaded question. What has your experience been in supporting people with IDD and substance use? Oh, rehab centers not being able to cover the costs. That is true. Getting access to detox. That is also true. That is very true. So
yeah, I was just going to say, Michelle, I would add to that even psychiatrists, they won't even refer to some of those programs because they know they won't fit the mandate. So
exactly.
they get the barrier before even applying for it.
It's such a tricky thing because addiction services, like funded addiction services, are very hard to come by. It's like they're kind of in the same way. Like, I always said, like, developmental services is like the ignored younger brother of mental health. So is addiction. Like, it's, both of those sort of like offshoots of the bigger mental health umbrella need a little bit more care. So you're right. How do we get our guys into programs where they are not going to meet the eligibility criteria because they don't have necessarily the cognitive capacity to engage in the programming that's being offered? I mean, the solution is to have their own programming it meets their needs, but still. Oh, what do we have here? A lot of addiction services will only talk to clients, won't collaborate with the team. Yeah, the onus is on the client to initiate the services, and sometimes they can't. And Amy, it's a sad comment, but it's a true comment, and it's something that actually happens. And I think all the time, like, how does AODA impact this, right? Like, what are the responsibilities of the people providing services to provide the services in a way that meets the needs of accommodation of the person with IDD, with substance use disorders? So our team on the North offers clinical services during active use. That's amazing. The key is knowing when to pay for service to allow other supports and when to resume services. Yeah.
I guess, Michelle, my point is just like that you can, I guess, knowing how to, ensuring that people have capacity to know that you can offer services during substance use and when that needs to pause without penalizing people so that they lose service because and that they may be in and out of active use. So kind of when that kind of thing.
Yeah. So, like, making sure that, the eligibility criteria doesn't include like being clean from drugs, because we know that that's not really feasible. So then here we go. So how come this is not working? Okay, there we go. So clinicians and caregivers supporting people with IDD who have substance use or substance use disorders often report a lack of knowledge and a lack of skills to be able to effectively treat the disorder and support the person. I have seen that across the board. I'm sure many of you feel that way. What are we going to do if we don't really know how to do it? So Vandernagel, and you can notice that at the end of this slide, or rather at the end of the presentation, you'll get all of the references that I use. These Vandernagel et al. Did a lot of work on this exact thing, on substance use and caregivers within the developmental services sector, and how their perceptions really do impact the clinical outcomes of people with IDD who have substance use. And they found that the perceptions of substance use as a behavioral problem or a moral failing might cause caregivers to offer ineffective interventions based on these perceptions, which in turn might explain struggles in reducing client substance use disorders. Jennifer, you still have your hand up? No? Okay. Oh, we have a comment here. Some clients present denial of substance use issues. I mean, 100%. That's true. If clinicians and caregivers perceive the substance use as a moral issue, then they might be reluctant or treat the person and or refuse to treat the disorder altogether, rather than seeing the substance use disorder as a disease and the person worthy of forgiveness, understanding, and empathy. I think this is the point sort of that we were trying to build up to, is that, you know, it's the perception of it as a moral issue and a moral failing, and the addiction being in the hands of the person who's struggling with it, causes some of our guys not to get the treatment that they need, right? And that is why we talk about harm reduction. So clinicians and healthcare professionals, so general practitioners, psychiatrists, pharmacists, social workers, whatever, regard treating clients with substance use disorder with negative attitudes, describing the process as challenging, stressful, and difficult. I mean, as compared to people without IDD who have substance use disorders. Negative attitudes increase barriers to accessing care, affect the quality of care that people with substance use disorders receive, and impact the treatment outcomes. So before I do this, any thoughts on that? Has anyone seen this happen in their own experience with working with people with substance use disorders? Maybe. Are there any ways in which, like, you've seen staff or your own biases around this come out? You can private message me. I wouldn't even tell anyone your name. No? Okay. So then onward and upward. So we pointed out that it is necessary to engage in some learning around risk severity and around drugs in general, and alcohol and substance use. So here we are, providing you with some information about how substance use and substance use disorders can have a serious impact on the body. I'm going to be giving out these slides also and sending them out at the end of, I'll send them to Tammy and to Deanna, and they can send them out to everyone else. So you'll have this information. And I would encourage you, if you're working with people with IDD who have this stuff, who have substance use disorders, to go through this information with them. And we'll give you some helpful hints later on how to do that. But please do keep it. So when we talk about opioids, they can slow breathing, they can result in ineffective breathing, which can lead to decreased oxygen in the blood, brain damage, or death. We talk about stimulants, so that's cocaine, crack cocaine, methamphetamine, amphetamines, and they can cause acute health problems such as stroke, heart attack, abnormal heart rhythms, seizures, as well as more chronic conditions such as heart or lung damage. Stimulants are particularly difficult with our guys because many of them take stimulants already on a daily basis in order, for concentration, all sorts of other things. So when they're engaging in recreational drug use with stimulants, it can really increase the risk of heart attacks and of cardiac issues, and it's a serious overdose risk. We had, unfortunately, an individual pass away recently in our service for this exact problem. The use of drugs by smoking or vaping, for example, heroin, crack cocaine, marijuana, can make chronic obstructive pulmonary disease, or can result in COPD, asthma, and other lung conditions. Conditions that affect the immune response, such as HIV, are more common among people who use drugs, especially among those who inject drugs. So I'm going to let Abby lead this one.
So we're just going to go through some like tips and tricks, I guess, for supporting clients with IDD. So the most important thing is to stay informed and to make sure that you have the updated information and consult experts if you have to. Make sure you know what to look for, what they need, and then determine if you're the right person giving the information. So you might have a colleague who has a better rapport with someone, and it's important that you assess that when delivering information around harm reduction to determine where they might go with it. And then again, use simplified language. So try to avoid overly scientific phrases and expressions and focus on tangible, concrete information. For example, rather than saying cardiac arrest, you say heart attack. Working in CAMH in a hospital, this is something you see a lot and something we have to work on a lot. And then break it down into the manageable pieces of information and be prepared to share the information in multiple sessions and in multiple formats. I think this is the next one. Oh, and repeat if necessary, just to make sure that it's accessible and they understand what you're trying to say. And then accessibility, if you can, present the material in a way that meets the learning needs of the person that you're supporting. So if you need to write it down or call them multiple times, say it face to face, whatever it is. So be prepared, have the information written down and have something for the person to take away with them as a reference. And then anticipate any uncomfortable feelings is a big one. So have the responses to more socially awkward questions. For example, do you use drugs? Prepared in advance. If you're disclosing that you use drugs or recreational cannabis, legal things only, how will this disclosure help your client and how might it hinder your client? Inevitably, you'll see some of these questions, so it's just important to anticipate them and make sure you know what you're going to say.
Oh, I was going to go through this one. There was a study done on the impact of COVID-19 on substance use treatment capacity in Canada, but given, touch wood, that things may be calming down right now, I don't necessarily know that we need to go through these findings exactly, but I will send them out. It is super interesting. I just talked about how the decreased capacity and availability of substance use treatment throughout COVID, and it's all doom and gloom. But now there's still decreased capacity, so I guess it's still doom and gloom, but you can read it on your own time. Okay, we'll do that after. So I'm going to share this video.
Look, you're smart, you're cool, and you don't want to die, so you do things to reduce the harm of the risks you take.
Amazing.
That's called harm reduction. It's all around us.
Sexy.
Harm reduction is common sense. It stops people from being injured and dying from things that are preventable. It saves lives, it saves money. It's smart. Here's a fact. Last year, 47,000 people died of drug overdoses in the United States. Because you're smart, you know these deaths are preventable. But here's something you may not know. Some kinds of prevention don't work.
Just say no. Who taught you how to do this? Any questions?
It's time to stop the drugs.
We've tried all these things, and still the number of people dying of overdoses continues to rise. But remember, you're smart. And because you're smart, you want to stop these preventable deaths. Do you know what is clinically proven to work? Harm reduction. You remember that, right? Harm reduction works for people who use drugs. It knows that people aren't perfect, but they deserve every opportunity to be as safe as possible. It encourages people to get educated and connected with healthcare. Harm reduction provides access to naloxone, the drug that reverses overdoses. It provides people with sterile supplies to prevent the spread of HIV and viral hepatitis. And when harm reduction is implemented in its most effective form, it gives people who use drugs access to supervised injection facilities in order to provide life-saving interventions in the event of an overdose. In 102 supervised injection facilities worldwide, there's yet to be a single fatal overdose. With more than 47,000 overdose deaths each year, what are you waiting for? Support safer, healthier communities by supporting supervised injection facilities in your city today. Learn more at www.harmreductionactioncenter.org.
Anyone unfamiliar with the term harm reduction? Which is like totally fine if you are. Okay, so this was not news to anyone. So here is something. Harm reduction has received a bit of a bad reputation. You know, supervised injection facilities in particular are something that we see across the board people are not super comfortable with. And my question is, does it matter if you personally feel an approach to treatment is right or wrong? As a caregiver, as a paid caregiver or a paid clinical support, I'll say. Should this be something, does it matter? Not should it matter, but does it matter? Does it matter how you feel about a treatment for the client that you're supporting? How much should our feelings about a treatment influence the person's right to make a decision or the right to receive it? Because we have, you know, like when we think about our work with people with IDD, we do have a lot more, you know, power and influence when we talk about dynamics than we do maybe with people who don't have IDD. Oh, here we have in the chat. It shouldn't matter, no. As clinicians, we strive to rely on evidence-based practices and interventions. It should, as long as it's the best, as it's in the best interest of the client. It should, but the question is, does it matter? I would go as far to say as it does matter. If we personally feel an approach to a treatment is right or wrong. It matters in a big way because the way that we feel about things end up impacting the care that people are receiving. And like, you know, whether or not we do it intentionally, but our biases do come through. And so I want you to consider that while we start now this next phase of it. Like, what is harm reduction? Harm reduction values life, choice, respect, and compassion over judgment, stigma, discrimination, and punishment. What does that mean? Does that mean we're celebrating drugs and we want people to be doing drugs all day? Absolutely not. So I want to talk a little bit about, is everyone aware of Insight, which was a safe injection site in Vancouver, and there was a whole thing with the Supreme Court of Canada, and they closed it. And there was a legal case, and they wanted to determine whether or not, you know, they could stay open and they could provide this sort of service to the community. And so the Supreme Court of Canada eventually said this: the effect of denying the services of Insight, so the safe injection site in Vancouver, which was the first safe injection site in our country, to the population it serves, and the correlative increase in the risk of death and disease to injection drug users is grossly disproportionate to any benefit that Canada might derive from presenting a uniform stance on the possession of narcotics. So what that is to say is, you know, criminalizing people for using drugs rather and closing safe injection sites rather than keeping them open and not criminalizing them. It's an issue. It only increases the risk of death and disease. So that is to say that harm reduction saves lives. So what are the principles of harm reduction? Why is it so, like, what is the drama around it? It's non-judgmental approach that meets people where they're at. It's very much in line for any social workers sitting here. It's very much in line with our code of ethics. So treating all individuals with dignity, compassion, and respect. There's an opposition to the stigmatization of substance use disorder. Use of evidence-based policy and practice, as noted in the chat just now. And accepting behavior change as an incremental process. Small gains for many people have more benefit for a community than large heroic gains achieved for a select few. People are much more likely to take multiple tiny steps than one or two huge steps. And I think this, it's not just in relation to drug use. Like, think about it, you can apply harm reduction to anything. Like, think about it in relation to dieting, right? Like, I don't know how many yo-yo dieters there are out there, but I certainly was one many, many moons ago. And I'll tell you, it's better to do multiple tiny steps than large heroic ones. It's not sustainable if we take a lens that is just like an all or nothing approach. Inclusion of individuals in active addiction, in recovery, and within the community to shape policies and practices. This is so important, and it's what we should be doing across the board with any sort of service, is getting the viewpoint of stakeholders who are receiving the services. Focus on quality life improvements over abstinence. Commitment to universal human rights. Empowerment of the individual as the primary agent responsible for reducing the harms related to their substance use. And that's an important one. It's a movement away from more of like a medical model of treatment, or like more of a paternalistic approach. We want people to be empowered and to be in control of their own treatment and to be the agents of change within their life. And we can't force people to do something they don't want to do. Harm reduction is the strategies and ideas aimed at making drug use safer. It's evidence-based and client-centered. It is an attempt to reduce the harm associated with drug use without demanding abstinence. It provides people who use substances with information that will minimize harm through non-judgmental and non-coercive strategies, with the goal of skill building to help them live safer and healthier lives. It acknowledges that people who use substances may not be in a position to remain abstinent. It provides an option for users to engage with peers, medical and social services in a non-judgmental way that will meet them where they're at. And, this is so important. And I think one of the most important points, because if we are judgmental, people aren't going to be honest with us, and we're not really going to know what the issue at hand is. Addicts have a tendency maybe to not tell the full truth. It happens, or I shouldn't say addicts, people with substance use disorders, I'm sorry. But it's true, and especially, you can get your back up when you feel that the people are judging you, or the doctor is going to be upset with you. And I've seen this with clients all the time when we're supporting them through this sort of issue. Meeting them where they're at just means like coming at it from a way that they don't feel judgment every time they report something negative, that we're not coming at them with this punitive response or telling them that they're bad or they're somehow messing things up. Not that we say that out loud, but sometimes we tell them that with our behavior. Allows for health-oriented responses to substance use. And it has been proven that those who engage in harm reduction services are more likely to engage in ongoing treatment as a result of accessing these services. So that's far nothing bad. So sometimes people are a little bit more, or not people rather, but agencies or organizations or programs are a little bit more covert when describing that they're a harm reduction based program, because again, the terminology gets people's backs up, right? So there is stigma attached to it. So they might say, we're a strength-based program. Drug abuse is a health issue. It's similar to mental health is health. The support, not stigma. Client-centered. There's more than one path to recovery. Not everyone is ready to stop using drugs. Meet people where they're at. So all those sorts of things are great indicators. And if you see programs that have this language, you should definitely go there with your clients. But we also recognize that harm reduction is a spectrum. And we think of harm reduction goals on a continuum, so ranging from small changes for safer use all the way to abstinence. An example of harm reduction goals. So for example, we can say use drugs with a buddy and carry an naloxone kit. So we're not necessarily telling them that they can't use the drugs or that, we might have a problem with it, but we're saying at least do this for me. If you're going to use it and I already know that you're going to do it, just use it with someone else, and here's an naloxone kit. Use via inhalation instead of injection. Reduce the amount and frequency of drug use. And then abstinence is also, it can be an example of a harm reduction goal, but it's not one that is frequently used. So harm reduction is different from what we call primary prevention. So that's preventing the initial use or the delay of the initial substance use. Now, the reason I have the slide up here is because how do you think this might relate then to people with IDD, with respect to drug use in general? Because primary prevention, for maybe the general population has to do with education programs in school and receiving that sort of information and having parents give information around drug use and substance use. People with IDD maybe don't have as much of the primary prevention programs aimed at them, which then increases their risk of using substances and having substance use disorders. Just something that must, from an advocacy lens, something to take into consideration. Okay, so what are the benefits of harm reduction? We have research shows harm reduction activities can increase referrals to support programs and health and social services, reduce stigma and increase access to health services, reduce sharing of substance use equipment, reduce hepatitis and HIV, or reduce rates of hepatitis and HIV, I should say, reduce overdose deaths and other early deaths among people who use substances, including alcohol, increase knowledge around safer substance use, increase knowledge around safer sex and sexual health, and increase condom use. Some examples of harm reduction. We have needle exchange programs, safe injection sites, safer use sites, Narcan or naloxone medication. Everyone knows what that is, right? There's no one, and if you don't, please don't hesitate to message me. Education on safe drug use practices, counseling to manage substance use, goal choice and flexibility, opiate replacement programs such as methadone and Suboxone clinics, and decriminalizing drug use. Behavior-based harm reduction strategies. So we have using small amounts of drugs at a time. And these are things, by the way, that you can, and I would share with clients that you're supporting or people you're supporting who have substance use disorders. Encouraging these sorts of things, even in a casual way. I know sometimes we get scared, I've had people come and say oh, I'm scared I'm going to get fired, I'm going to get in trouble for telling them to use drugs. But you're not telling them to use drugs. You're telling them if you're going to continue using drugs and alcohol, do so in a way that reduces the risk of harm to you as much as possible, right? You know that there's inherent harm in using drugs, but you also recognize that a person can't stop using drugs until they're ready to do so. So with that, I say then, encourage them to use smaller amounts of drugs. Tell a friend or family member when you're going to be using and ask them to check in on you at specific times. Use an overdose prevention smartphone app to ensure help is called if you need it. I don't know much about those apps, and I would encourage, if anyone has ever used them, if you could put it in the chat if there's one that you can use, it would be great. Something that I'll do some research into, but I don't know much about. So if you use opioids, including heroin or other drugs such as cocaine that might be mixed with opioids like fentanyl, provide naloxone to a friend or family member who will check in on you if possible in case you experience an overdose. I believe there are kits that you can get to test if there are traces of opioids in recreational or street drugs. So figure out where those things exist and share them with And if you don't have naloxone, talk to your healthcare provider or contact your local pharmacy. I should say most provinces allow pharmacists to dispense naloxone without a prescription or get access to this medication. So
Yes, sorry, I will just add to that. I know from experience you can get naloxone kits at like most Shoppers Drug Marts. Like
Yeah.
they're not hard to access.
honestly, they're all over the place now. Like I've noticed, and now that we're coming into like, we have summer street festivals and all these sorts of things. I've noticed recently that there's like always a little booth with it, with like 2 public health nurses and a naloxone kit, which I think is so brilliant. So even when you're out and about this summer, like check it out and take all the naloxone kits. I have so
I
many.
just saw a question in the chat. Are they free? Yes, they're free. And if you pick them up at a pharmacy, they will offer you training in them as well.
Yeah.
Most of the time.
It's similar to like, you use them that you use like the EpiPens. Like it's the same sort of needle. But they're relatively easy, and you can just go up to any pharmacist will be happily sharing with do a training. So why is there such an intense stigma surrounding harm reduction as an approach to caring for and treating people who engage in substance use or have substance use disorders? Because we just went through all the stuff and it seems, pretty good, pretty healthy, pretty great, actually. So why the stigma? But this I really hope that you contribute to in the discussion, because it is I want to know your thoughts.
Michelle, there was a comment from Amy a while back, just where she was talking about working with the client's family, where the mom supports them, but the rest of the family has, I'm just reading from her, has stopped talking because, sorry, I can't read it too. They think he's beyond help and has relapsed too many times.
Okay.
So I'm thinking like the mom's still supporting, but the rest of the family has stopped talking to them. So I guess they want more of the abstinence, right? And this is someone that probably the family could benefit from. Is there a way to support families? Is there with harm reduction, like giving them more information on that?
Absolutely. Like I think supporting families, it also is, there's a psychoeducational piece too, right? I think it's less about supporting them through the harm reduction, but more supporting them in what it actually means to have a substance use disorder. And because we have a tendency as humans to attribute people's behavior or to misattribute people's behavior, I think. And I think at times it's really difficult to see people, especially when you're being negatively influenced, like as a family member, by someone who has a substance use disorder. Like you really think like they really mean to do this, right? Like, and you get pissed off because you're receiving the brunt of a very difficult and complex disease. So maybe, engaging in the in psychoed around harm reduction, around substance use disorders, having the family access their own treatment and counseling support around having a family member who has an addiction. Certainly accessing like mutual aid groups and support groups is also a helpful thing to do. But, there's no like, one shining answer. But I think approaching it again from a way where we're being non-judgmental and we're trying as much as possible to destigmatize substance use and substance use disorders is a start. But yeah, I don't know. There is, but I want to come back to this question though. Like, why is there such an intense stigma around harm reduction? Because for all intents and purposes, it's a pretty neat approach to treatment. I think the belief, okay, so we have here from Sherry. So I think the belief out there is that it enables the addict or addiction and does not provide them with a bottom. Yeah, someone recently said this to me when we were debating it. 110%. Yes, you're right. People think that we're encouraging. I feel like it's endorsement of drug use. Exactly. But is it? 100% no. Right? It's just telling people that you're going to be as safe as possible when you're doing this thing that right now you're not ready to stop doing. And it's acknowledging that we don't have the right to control other people's behavior. And indeed, us, putting someone and not giving them access to their drugs and saying, well, this is a treatment and now it's solved, isn't actually addressing the issue at hand. And when they have the opportunity, they're going to engage in substance use again. So I'm just aware of the time due to my fire alarm incident last night. I'm really sorry again. I don't necessarily know that we have time for a case study, but I will leave this inside the PDF or that I sent out. So, harm reduction for people involved in the justice system. So, drug treatment court is an example of harm reduction. It's similar to mental health diversion, but meant for people who use substances who committed nonviolent offenses as a result of their addiction. Any of you here have involvement with a drug treatment court with your client? Maybe. In the UK, there's an arrest referral program. There are arrest referral programs where police stations have a specially trained substance use assessment worker who offers counseling and referrals to treatment programs for arrestees who voluntarily request assistance with their substance use. In Vancouver, police only attend overdose ambulance calls if requested by ambulance personnel. This has shown to reduce the risk of overdose deaths because people are more likely to call for help if they know police are not likely to be at the scene. Police are positioned to provide education and information on safer drug practices, including pamphlets and location of harm reduction services. In correctional services or the Correctional Service of Canada programs, prisoners are not excluded from substance abuse treatment if they're actively using. Abstinence is not a condition of participation in substance abuse programs. And I think as a general rule of thumb, this is the case across all programs that have set harm reduction as sort of their guiding philosophy. Abstinence shouldn't be a condition of participation in substance use programs because we know that it's hard to stop using drugs. So why should a person be barred from treatment while they're struggling with the disease itself? It's like saying to a person, you can't go to the depression clinic until you're not depressed anymore. Makes no sense. Positive cannabis results are assessed with discretion in parolee urinalysis unless specifically connected to the offender's criminality. I think we see that across the justice system. Some countries and provinces provide bleach to inmates to sterilize injection equipment, which is huge. Some countries provide needle exchange programs in jails. Methadone maintenance therapy is provided to opiate-dependent inmates and parolees. So harm reduction can be applied to other risky behavior as well. So, it's used in schools to discuss sex education and safer sex. It's discussed within the context of legalization of prostitution and sex work. It can be applied to gambling or other high-risk behavior. I mean, it can be applied to all sorts of things. It's the most beneficial way that research suggests to deal with substance use and substance use disorders. So we know that it works. But there are criticisms. And again, I mean, people in the chat said before, people think that it's going to encourage drug use and all this sort of things. And that's, more or less what those criticisms are, right? It doesn't actually stop actual drug use, right? That's the criticism, because you're telling them that you don't have to stop. But the answer to that is, that's the whole point. After every criminal and societal sanction we put in, people still use drugs and people still die. Harm reduction reduces substance use related fatalities. And that's the key point here, right? I think when we're in the argument around around harm reduction, people, they're quick to say, well, you're going to see people doing drugs in these injection facilities, but we're not concerned about that. We're concerned about the deaths. And all we know is that it reduces deaths. We're giving up on people by not focusing our attention on treatment and recovery. We're not giving up. If recovery is going to happen, we have to keep them alive, offering a clean needle and a safe place to inject so that they remain alive to be able to undergo treatment. Harm reduction gives the wrong message to our children about drug users. I don't know. This is I was watching an interview with someone who's saying, well, we're glorifying drug use because we're giving these really great places, these injection sites for people to go and use drugs, and it's teaching our kids that drugs are really cool. I don't think that that person had gone to a safe injection site. So substance users are also our children. Safe injection sites are not enticing places. They're not glamorous. They're full of people who are sick and hurting and struggling. And so the message we're sending to our children is that drugs are dangerous and they can hurt people, but we still care about them and we want to help when people get sick. I read a beautiful quote the other day about not letting your beliefs hide or shield you from the humanity in other people. And I think this sort of resonates with me here. Like, just because we believe drugs are wrong doesn't make drug users bad people and shouldn't make us less inclined to help them. Harm reduction encourages people to use substances, and again, research suggests that harm reduction activities do not encourage substance use. In fact, they encourage people who use substances to start treatment. So, the treatment of substance use disorders in people with IDD relies on clinicians and caregivers having a working knowledge of the factors that lead people with IDD to an increased risk of substance use disorders. So, if that's the case, then we as people who are supporting people with IDD need to become aware of those factors and make it our business to educate ourselves and families and people and our colleagues, because without education, without awareness, we're not going to get to the root of the problem. Any intervention, be it harm reduction or otherwise, must work to treat the root cause of the substance use disorder and work within the context of the individual's social location. For example, teaching strategies to individuals with a developmental disability in a way that optimizes their learning styles and meets their developmental needs, while offering strategies to caregiver and family members to support the person's learning. We must value the role of caregivers in the lives of people with IDD. That's incredibly important because we have way more, I use power and control just because that's what it is. We have a lot of power in the lives of the people we support, more than we would if they didn't have an intellectual or developmental disability. The very nature of living in, congregate care settings is that you're putting your life in the hands of your caregiving in the hands of other people, and those people have an influence and impact on what happens with you and what happens with your treatment. So let's value ourselves and our role and value families as well. It's imperative that we consider the intersectionality of the experiences of people we support. Individuals in supportive housing are subject to restrictions and guidelines that adults typically don't experience in their lifetime, even more so if they're involved in the justice system or the forensic mental health system. Our treatment plan should always reflect an appreciation of people's lived experiences and circumstances, and I'll add, as much as possible, take an empowerment-based approach where the person, if they can, contributes to their treatment and makes treatment decisions on their own behalf that are informed. So this is reflection questions. This you take with you as you end and you do the rest of your day. I want you to think about things like, do you choose your illness? What are your values and beliefs regarding harm reduction approaches? What are your values and beliefs regarding some of the challenges that your clients are facing? And how do your values and how do your beliefs impact your caregiving? And then the last one is, does harm reduction actually save lives? It does. So I'll end with this quote. When we make decisions based on fear, liability, and hypothetical problems, we're shutting down various conversations. So if we're making decisions based on fear of drugs and drug users, we're not actually getting any discourse and any solution focused talk done. And with that, I end. So any questions, any comments, any concerns